How are you, Dr. John?
Hey, Omar, how you doing?
Alhamdulillah. How? Thanks God.
Okay. I'm not sure. Got a new camera. Other one broke. How you guys doing? Yeah. Okay, I'll be back.
Dr. John?
Hi,
Hello?
welcome, Igor.
Welcome. How are you?
Good.
Just one point. I had a difficulty to join because the web link was not correct. There were repeated HTTP or something.
Okay.
The link was not correct.
Well, you use the same link you use. It's the same link.
But when I click the link in the poster, it's not
Okay.
working.
Okay, let me give you okay.
So now I solved the problem, but it's for the people, you know.
Yeah, a lot of people, a few people.
Yeah, the many people couldn't join because the link
Really?
was not correct. And then,
Really?
yeah, I
Wow.
noticed that the link there is a mistake in the link.
Okay, because it's difficult because if you access the internet from a country that has restrictions against Facebook, sometimes I use a link shortener because Zoom gives you a link that's really long. Okay, so I use this service to make it smaller, but apparently it's a Facebook product, and places like China don't use Facebook products. So I have to, like for Dr. Bin, for him to come in. I know this is long and dull. For Dr. Bin to come in, I can't give him the regular link. I've got to give him the long link. Do you understand?
Yeah, a little bit. But
yeah, a little bit.
there is
Okay.
a typing error in the link. There is a typing error.
I do
This
make
is my
those.
fault.
I do make mistakes.
Yeah, there is a typing error
Okay.
because HTTP mistakenly wrote 2 times.
Two times.
know the-
Okay. Okay.
Yeah, so there is a typing error. This is my point.
Yeah. I make mistakes. I just can't make too many.
Mhm.
So you're in Slovenia. Where you're in Slovenia, correct?
Turkish.
Oh, Turkey. Turkey. Oh, okay. I'm sorry.
No.
I'm sorry. Yeah. Okay. Yeah, you guys are active there in Turkey on the internet.
Yeah.
Matter of fact, we had a webcast with a neurosurgeon from Ankara who did one on artificial intelligence in neurosurgery. Yeah, it was very good. I'll send you a copy of the tape. We did it last Monday, and it went very well. Let me see if I can get it here. Hold on. Okay. So now I get my chance to screen share. This is the intersection of neurosurgery and okay, I'm sorry, hold on, let me get the sound, hold on. Stop share. You gotta make sure you put the sound up and on. I didn't do that.
How are you, Dr. John?
Okay, you can't hear that, right? Okay. Okay,
Anyway,
now
I can find it in YouTube. Yeah.
oh, there it is. Can you see it? Go ahead, Hosea. Can you see that? You're muted.
Scientist.
Okay.
I think technical problems always happens. So I think you can see my screen and the presentation, right?
So I'll send you that. I'll send you that.
Yeah. I can find in YouTube. Thank you very much. Yeah, thank you.
Yeah, I'll send it to you.
Thank you.
and we had a PhD from Ankara, no, not from Ankara, from San Francisco that works with him.
I see. I see. Very good.
Yeah, so he's pretty established, and he's going to have more webcasts.
Very good.
And yesterday, Dr. Borba had his webcast. Ali Krish presented at 8 o'clock. It was bad time for you. 8 o'clock at night in Brazil, I think, is 3 in the morning. In Turkey, it's very bad. How you doing, Omar? You know Omar Ugar?
How are you?
How are you?
Hi, Dr. Gore. How are you?
Omar's from Syria.
Nice to meet you.
Thank you, Dr. Gore.
Thank you.
He's one of our best students.
Thank you. Best professor, Dr. John, also.
Okay, if you say best, I'll say best.
Okay. Thank you.
12 minutes. You has not arrived. Okay, I'll be back.
Check my videos. Dr.
Yeah, go ahead. Go ahead.
Yeah.
Go ahead.
So I have to do share screen.
Yeah. There you go. Okay, yeah, there you go. Okay, play the video. You want to play the video? Does it have sound? Does it have sound on the video?
Yes.
This is a case of 14-year-old boy who presented with
Can
a
you
long
hear well?
history of
Yeah, okay, you need to do something. It's fine. It's fine. I can hear it. I can hear it.
So
Yeah, it's fine. It's fine.
Fine? Okay.
Yeah. Because play it again. Play it again. We'll see if the sound comes. Play it again.
This is the case of 14-year-old
It
boy.
plays. Yeah, it plays. It's okay. It's okay.
Severe headache.
Because
double vision.
some of my videos has a sound and it's better than my English. So
Okay. Well, we
Okay,
tried.
okay.
I think it'll work. I think you are set up. I think you are set up correctly.
and this one.
The case of a 51-year-old man who
Yeah, it's
presented
fine.
temporary episodes
Is
of
it
double
okay?
vision.
Yes.
He only created images.
Okay, thank you.
So you're all set.
Okay. Stop share. How I can stop share?
Yeah. At the very
Yeah,
top of the
okay.
screen, the top of the
Yes,
screen.
okay. Yeah. Stop share. Okay.
Dr. Gore,
Hi.
are you live at Istanbul or where?
Who are you?
Where are you now, nowadays? Istanbul or where?
Istanbul. Yes, I am in Istanbul.
I am at Idlib. You know Idlib?
I cannot see you.
I am at Idlib, Syria.
Ah, I see. I see. How are you? I see.
Alhamdullah,
Yes.
thanks.
Yeah,
I am Idlib, Syria.
I see. So, what city now you are?
It's Adana. I know Adana at Idlib, Adana.
I
My
see.
clinic, my private
Idlib.
clinic at Dana.
Idlib,
Operation Idlib and Dana Hospital.
Good. Very good. Yeah. If you come to Istanbul, please visit us. Yeah, pleasure.
We have no permission to go to, like
Really?
government need permission. I have a passport. If you give me from Hatay, okay, I can enter to Istanbul.
I see.
Maybe
Difficult times. I hope it will.
For Corona, nowadays for Corona.
This is because of Corona, not politics. Okay.
No, politics. I have no
No problem.
Yes. Before I have been the passport of باب الهواء
Okay,
transport.
good.
No. Okay.
Yeah, after Corona, maybe.
Maybe after Corona, Salah.
Oh, good. Ben's here. Oh, good. Hello, Ben. Welcome,
Hi,
Ben.
Professor Cultura.
Hi, how are
Hi.
you? Hi, how are you?
Hi, fine.
Hi.
Hi.
So no
Hi.
no
Hi,
problem.
Professor. Nice to meet me.
So no problems getting in, huh?
Hello.
Mhm.
Hello.
Hello,
Yeah,
hello.
yeah.
Did you?
Yeah.
Hi.
Dr. Juha, Professor Juha.
There's still some.
How are you?
I'm
from
fine,
all?
fine. Thank you. Thank you.
From
Thank you,
all.
Omar.
First, thank you.
Hello, Guru. Hello.
Hey, how are you? Thank you. Thank you.
Yeah, fine. We have to clear some Chinese advertisements here.
Oh, okay. Well, you know, it is changing, Juha. There are some producers that are putting like commercials on the webcast.
It doesn't look so. There are nearly naked females and so.
Okay. Well, no, yeah, I don't know. We have that yet.
These are Chinese junk.
So, Professor Torreira, we already advertisement for your presentation from yesterday. Now the reader is almost 2,000.
Oh, wow. Great.
2000.
Yes.
Wow.
Have you ever spoken to that many people?
2000, never.
Mhm.
Yeah, last time when we were speaking, there were
Yeah.
after the weekend there were more than 2,000.
Yeah. The exact number is 1,938 till now.
Oh.
Yeah.
Yeah,
Wow.
During the weekend, 1,000 usually is coming more.
I see.
You know, we did a series with Dr. Chris and Dr. Lawton, and that's doing very well, Ben, on over there on medtion.com. I'm following. The series continues to grow. So that's a good way to give webcasts is in a series, I think, in China,
Yeah.
because it'll last. Okay, 4 minutes. Let me try to get a hold of Dr. Takashi. He said he's coming.
عندك كرسي؟ كرسي برا، كرسي برا تجي. ليه كرسي هناك؟
Oh, look, Juha, there's another Finnish neurosurgeon. Are you there, Joanna?
Hi, John. Hi, everybody.
Hi.
Hi.
Joanna's from Finland, from Helsinki. I guess
Yes.
you is home.
Yes, nice to meet everybody and have a good webinar. Looking forward to this great experience.
Thank you.
Is that okay now?
Oh, actually, my background.
This one I couldn't. Oh, now you could close.
Yeah, 2 minutes.
Ortyre is down. Mhm. So the first one. Mhm. Yeah.
Okay, ready to start, Juha? Okay, here we go.
Yeah, it's okay for me. Yeah.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. We have another Juha's China Neurosurgery Grand Rounds with the return of Uyghur tour. And I'll let Juha introduce him. Welcome, Juha.
Thank you. Welcome, everybody. So I'll share my screen. Can you see it?
Yes.
Okay, so welcome, Professor Uyghur. He's from Istanbul and is chairman of the neurosurgery at Yeditepe University. Uyghur is certainly one of the most important neurosurgeons of these times in the world. How to become a good neurosurgeon? I have always asked this question. I never saw a neurosurgeon who wanted to be a bad neurosurgeon, but how to become an excellent neurosurgeon. You have to select heroes and mentors. Of course, all the world has as hero Professor Yasakil, but Uyghur has had a very special position because he has been also studying with Professor Yasakil so many years and now is co-working with him. So this is a very special position. How to become an excellent neurosurgeon? You have to learn anatomy. You have to follow the way Professor Uyghur has been doing. He has spent 5 years in cadaveric laboratory. Many said that time that he's spending his time, but he was not doing that. He was learning extremely good anatomy, especially fiber dissection was that time new, but now when we can see the fiber tracts in MRI, so it has become extremely important, these studies. Neurosurgery has 3 parts, operative skills. These are by Uyghur extreme high, research, clinical and basic. He has done many anatomical studies, and then teaching, like we are now doing in congresses and webinars during the COVID time. Professor Uyghur is doing extremely skillful surgery at Yeditepe. I have been following that many times. For that, you have to be excellent neurosurgeon, organizer, to have the best facilities and to be surrounded by good, excellent supporting team and the patients and society. And you have to have a constant flow of the patients to treat your patients and to do your surgeries. What I have seen at Yeditepe, all patients have impressive preoperative studies. There's utmost planning of the surgery, extreme good video documentation of every operation, and then also of outcome and very careful follow-up. This is what I have seen, and so many who have visited there have testimonied. So if you want to see and learn good microneurosurgery, go to see Professor Ugur Türe in Istanbul at Yeditepe. So I welcome you all to this excellent webinar following now on treatment of thalamic lesions. Please go ahead, Ugur.
Thank you very much, Juha. Thank you very much, Professor Hernes Niemi, my mentor. Thank you. It's for your kind words. So, yeah, can you see my screen?
Yes.
Yeah, okay. So today I would like to talk about the microneurosurgical removal of thalamic lesions. It depends on my 15 years of experience and almost 120 cases. So my talk will be a summary of my experience in thalamic lesions. The thalamus is the part of the diencephalon and consists of interconnected ovoid nuclear masses and connected with the telencephalon cranially and with the mesencephalon, rhombencephalon, and medulla spinalis caudally. The term of thalamus is the old Greek word. It describes the innermost chamber of old Greek houses, and which is the married couple lived there. So it is the most inner chamber of the Greek house. And the first time, Galen of Pergamum, the famous neuroanatomist, mentioned used this term of thalamus. And the thalamus is commonly regarded as a gateway for all inputs directed to the telencephalon, and it plays an important role for somatic, vegetative, and cognitive functions. And when you read the functions of thalamus, and then when you study the location of thalamus, and then when you see the arterial and venous vascularization of the thalamus, it looks like it's untouchable. What we can do there, how we neurosurgeon, how we can reach there, but it's possible to reach, and it's possible to remove many lesions in thalamus. And this is the region that the surgical approach is not very common, and mostly the conservative attitude are accepted in all over the world for the thalamic lesions. I spent a lot of time to study the thalamus anatomy, and then of course I saw the best thalamic surgeries from my mentor, Professor Yaşargil. And this was the reason that I involved this field. But another point is it's very important point is the good neuroanesthesiology, because without good neuroanesthesiology and the intensive care, I think it is really very dangerous to perform these surgeries. Main syndromes in thalamic lesions are raised intracranial pressure, motor deficit, sensory syndrome, involuntary movements, and seizures. And these are real deep-seated lesions. And the majority of these lesions are focal at diagnosis and amenable for surgical resection. So surgical treatment is still challenging because of this location and the vascular anatomy. Intraoperative ultrasound and intraoperative MRI are valuable, and of course intraoperative neurophysiologic monitoring. Surgical approaches of thalamus. Now, the most common approach to thalamus is through the lateral way, through the neocortex. In my series, I never perform lateral approach to thalamus. The thalamus is half of the thalamus surface just covered by the internal capsule and corona radiata. And we should not go this way. Other side of the thalamus has some surfaces which I will describe. But if you go laterally, you have to cut most of these fibers. And another problem, if you go from laterally, you have no orientation. So all of my surgeries are done through the transcisternal or transcallosal. And this is the summary of the thalamic peduncles. Thalamus is in the center of the brain, and we have anterior, superior, posterior, and inferior thalamic peduncles. And the posterior thalamic peduncles include the optic radiation and auditory radiation. And Dr. Sarah from Switzerland, my fellow, studied this anatomy and published it very well. And we find out that there are 4 surgical surfaces of thalamus: lateral ventricular surface, velar surface, cisternal surface, and third ventricular surface. In any case we saw in the MRI, we have to find out which surface we can use for surgical resection of the thalamus. We never perform lateral approach to thalamus. Just we perform transcisternal or transcallosal approaches. And we describe this anatomic study with Dr. Sarah. You can find this detailed anatomic study. And my surgical approaches belongs to this philosophy. And this is the summary of my surgical approaches. I use 4 surgical approaches to thalamus. A is the anterior interhemispheric transcallosal approach. This is the only approach that we have to cut some callosal fibers. Other 3 approaches are totally transcisternal. B is the posterior interhemispheric transdentorial subspinal approach. C is the perimedian supracerebellar transdentorial approach. And the last one is the perimedian contralateral supracerebellar suprapineal approaches. And I would like to show some samples of these approaches and how I select the cases. First one is the anterior interhemispheric transcallosal approach. This is the best approach for anteriorly located thalamic lesions. And we can use the lateral ventricular surface of the thalamus to get the tumor. And there is no cortical incision, but we have to do callosal incision. And another advantage that you can see the whole anatomy of ventricle and thalamus. When you start surgery, you have total orientation of thalamus, and also you have total orientation for corona radiata and internal capsule. And this is the idea of the transcallosal approach. I use always right-sided craniotomy, and depends of the thalamus lesion. If the left thalamus lesion, I use contralateral approach. I am a right-handed surgeon, and its left thalamus tumor is easier to remove. But for right thalamus tumor, I still use the right craniotomy. And one of the sample, this is left always in my MRI. The right-sided anterior thalamic avia. And the patient had 2 months ago intraventricular hemorrhage, and he was comatose, but he recovered totally. And we find out there is an AVM in the anterior thalamic nucleus region, and receive blood from anterior choroidal artery, posterior choroidal artery, as well as thalamoperforating arteries. And this is the in supine position, right-sided anterior transcallosal approach. This is right foramen of Monro, fornix, and this is the clot, and the fornix is here, and I see the anterior septal vein and thalamostriate vein is here. The AVM is just post, this is thalamostriate here, and this is the cavity of the hematoma, and I am just turning around the hematoma cavity. This is thalamostriate, right thalamostriate vein. And it is 2 months before my surgery, this bleeding happened. So it is good time for also the resection. It is easier. And choroid plexus is here, right choroid plexus and choroidal vein. And this is totally anterior transcallosal approach. We have to preserve, of course, the thalamostriate vein. And I coagulate the choroid plexus also with the AVM. And this is right fornix, and this is choroidal fissure, and I remove the choroid plexus also, because there is the AVM receive blood from choroidal arteries, and I'm just turning around this is the inferior part of the AVM. And this is after resection AVM, anterior thalamic AVM, using anterior transcallosal approach. And this is endoscopic view of the cavity. This is the AVM was here, and this is thalamostriate vein, and foramen of Monro, right foramen of Monro here, and anterior septal vein. And this is left. The already bleeding already perforate the septum pellucidum. And here is the thalamostriate vein and anterior septal vein, and the fornix is here, and the internal cerebral vein is here. This is internal cerebral vein. And we perform also the ICG to see the venous anatomy is intact. So this is right thalamostriate vein, and here is the anterior septal vein and internal cerebral vein. So this was post-operative picture of the AVM, and this is after resection. The AVM is gone, and he recovered very well.
This is a case of 14-year-old boy who presented with a 1-week history of severe headache, double vision, and vomiting.
This is another case.
Neuroimaging showed a large tumor originating in the left thalamus. It extended to the supracerebellar cistern and compressed the tectal plate. Fiber tractography showed that the tumor displaced motor and sensory fibers anterolaterally. I prefer approaching the left lateral ventricle through the right-sided craniotomy for 2 reasons. First reason is to protect the dominant hemisphere, and second reason is being right-handed surgeon. Therefore, we carried out a right frontal parasagittal craniotomy, and the dura is open and hung under surgical microscope to protect the parasagittal bridging veins. The interhemispheric fissure is open with sharp dissection and cotonoids for retraction, which prevents harm to the medial frontal lobe. 2 pericallosal arteries lying over the body of the corpus callosum are recognized. To discern the correct callosal incision, we use cotonoid-guided ultrasonography, placing a small cotonoid between 2 pericallosal arteries. Ultrasonography shows that the estimated location of the incision is correct, and the angle of approach allows access to the entire length of the tumor. Instead of a sharp callosal incision, we first create an entry point with bipolar forceps and separate the callosal fibers, targeting the left lateral ventricle. The neuroendoscope is introduced to demonstrate the left lateral ventricle. At this point, we can see the left choroid plexus reaching to the left foramen of Monro, ventricular surface of the left thalamus, which is enlarged by the tumor, and the left fornix, as well as the caudate nucleus. The left choroidal fissure is demonstrated. The exposed part of the choroid plexus is coagulated and removed to gain more surgical space. The choroidal fissure is opened and the fornix is mobilized medially. With this maneuver, the grayish tumor tissue is well exposed. With power-controlled suction, the tumor tissue is centrally debulked. In this case, the tumor is easily suckable without the use of ultrasonic aspirator. This feature of the tumor is immensely helpful to differentiate it from the normal thalamic tissue. The posterolateral part of the tumor is removed with suction. The tumor between the fornix and the caudate nucleus is felt under the ventricular surface of the left thalamus. Resection continues at the posterior superior part of the tumor until the normal tissue is detected with its different consistency and color. Now, the tumor reaching the supracerebellar cistern is removed. This curved tip suction is especially useful in reaching hidden spaces. Posterior tumor bulk is felt under the left fornix. Therefore, to expose this tumor tissue, the fornix must be mobilized further by opening the choroidal fissure more posteriorly. After opening the choroidal fissure, the left fornix is stripped over the tumor. Power-controlled suction is used to gently pull the fornix. At some points, we use low-power bipolar coagulation to dissect the tumor fornix border. In this step of the surgery, the septum pellucidum is penetrated and the right lateral ventricle is opened for better CSF circulation. Now we moved anteriorly to see the left foramen of Monro. The tumor bulk herniating through the left foramen of Monro is visualized and resected with suction and bipolar coagulation. A small cotonoid is placed at the left foramen of Monro as a landmark to be removed later in the surgery. The anterior interhemispheric transcallosal approach allows for a microsurgical third ventriculostomy through the tuberous cinereum anterior to the mammillary bodies. The microsurgical third ventriculostomy is crucial to prevent postoperative complications related to CSF disturbances. Now, anterior part of the tumor is excised through the open choroidal fissure to reach the left foramen of Monro. The anterior superior border of the tumor is felt with suction, and the cotonoid at the foramen of Monro is reached by following the tumor. This landmark ensures the total removal of the anterior inferior portion of the tumor. Now, the left thalamostriate vein is demonstrated, and the tumor located at the roof of the third ventricle is removed. Now, CSF within the third ventricle is released, and right thalamus is seen medially. This represents the medial limit of the resection. After hemostasis is achieved through warm saline irrigation, the tumor cavity is checked with ultrasonography to confirm radical resection. Please note that the cortical surface is free of contusion, mostly due to avoidance of rigid retraction. The large parasagittal bridging vein is also preserved. A thin layer of gelatin sponge is placed over the cortical surfaces to to prevent postoperative meningocerebral adhesions. The dura is closed in a watertight fashion and the bone is fixed with microplates. Postoperative MRI confirmed radical resection of the thalamic tumor, and fiber tractography showed that the motor and sensory fibers have been replaced in their original formation. Histopathology analysis revealed the tumor to be an anaplastic astrocytoma, WHO grade 3. Therefore, we recommended adjuvant radio and chemotherapy. The patient was discharged on the 5th postoperative day with no neurological deficits.
So this was the sample of anterior transcallosal approach. And the second surgical approach is posterior interhemispheric transdentorial substitutional approach, which is totally cisternal approach. And this is an excellent approach for posterior thalamic pulvinar lesions. And under the splenium, without cutting splenium, we have great space to work. And the course of the cortical draining veins facilitates this access. And of course, the preservation of optic radiation is the main advantage of this approach. And I am going to show one sample of this approach.
The case of a 51-year-old man who presented with temporary episodes of double vision. T1 weighted images in axial, coronal, and sagittal planes revealed a left-sided posterior thalamic lesion. This lesion had a peripheral enhancing zone with a non-enhancing hypointense center. This is the preoperative fiber tractography study in axial and coronal planes. It shows that the pyramidal tract and medial lemniscus are displaced laterally, and the superior cerebellar peduncle is displayed anteriorly by the tumor on the left side. For such cases, we use the posterior interhemispheric substitutional approach with the patient in the lateral oblique position. This approach is suitable for most patients with posterior thalamic lesions and has certain advantages over other approaches. For this approach, the patient is placed laterally with the ipsilateral side down. The head is fixed in the Mayfield head holder with a rotation of about 30 degrees to the floor. This positioning helps the dependent medial occipital lobe to fall with gravity. The craniotomy is planned before surgery according to the course of the cortical draining veins shown on 3D reconstructed images. The upper limit of the posterior interhemispheric corridor is the parieto-occipital vein, and its relation with the lambda is identified when the craniotomy site. The exposure of the dura is shown here. It is taken all the way to the superior sagittal sinus. Thus, retraction of the dura pulls the superior sagittal sinus to gain more space. Some CSF is released from the subarachnoid space. Then, the first maneuver is to get alongside the pulse, so we can get directly to the splenium. This maneuver is followed by releasing CSF from the subarachnoid systems. While dissecting the arachnoid, the protruding part of the tumor within the cistern is revealed without any cortical or callosal incision. Arachnoid dissection is continued to expose the galenic venous system in the subsplenial area. Thus, the border of the tumor are revealed and more CSF is released from the cisterns. This is the inferior border of the tumor and the intact midbrain. This is the internal occipital vein, which is mobilized to reach superior border of the tumor. Bipolar forceps in various lengths and tip sizes and adjustable power suction are very effective tools during surgery. Initial central decompression of the tumor is carried out and biopsy samples are obtained. After we obtain enough material for histopathological and genetic studies, we use the ultrasonic aspirator, starting with low power and increasing as necessary. No necrosis or mitosis was seen on frozen sections, suggesting that this might be a low-grade glioma. There are certain difficulties during surgery of the thalamus. For example, the thalamus itself looks like a low-grade glioma. Therefore, it is not always easy to differentiate the tumor from the thalamic tissue. Real-time intraoperative high-resolution ultrasound is very helpful for checking the surgical area repeatedly. After central debulking, the lateral portion of the tumor is removed. Now, this is the medial portion of the tumor. For better exposure, a tentorial incision could be made. But in this case, there are venous lakes in the region which prevent such a maneuver. With the ultrasonic aspirator at low power, the medial and anterior portions of the tumor are removed. Now, the superior border of the tumor is separated from the fornix. The tumor is dissected from the normal thalamic tissue with bipolar coagulation. The remaining portion of the tumor is removed with the ultrasonic aspirator. A high-definition neuroendoscope is a great addition to microneurosurgery. The closer and wider look at the hidden areas with neuroendoscope allows better checking for residual tumor and hemostasis. Now, the right thalamus is seen through the third ventricle. The endoscope reveals residual tumor attached to the galenic venous system. This remnant is removed under the microscope. After the residual part is removed, the surgical area is checked again with the neuroendoscope. No cortical bridging or deep veins were sacrificed. One can now appreciate how the medial occipital lobe gravitated without rigid retraction. This is the advantage of the lateral oblique position. The intact splenium of the corpus callosum is seen in the superior part. The surgical cavity looks clean, with neither residual tumor nor any source of bleeding. The early postoperative MRI shows radical removal of the tumor. Patient has no neurological deficit, including visual field defect. The result of pathological studies showed a grade 3 anaplastic oligoastrocytoma. Therefore, the patient received adjuvant radiotherapy. No residual or recurrent tumor was seen on the 3-month postoperative MRIs. Postoperative fiber tractography shows that the fibers return their normal position.
And we published this surgical approach. If you want, you can look at it. And another case with the same approach. This is again posterior thalamic lesion, left-sided, 13 years old girl. And we again use this approach. 3.5 years ago, we started to have used the intraoperative MRI. So for this reason, I'm not able to use lateral oblique position anymore. I use prone oblique position for this case. And again, the cisternal surface in the left side. And then, therefore, we use, sorry. So we use the same approach. And this is intraoperative MRI. And it is nice to use it because that we do not need to leave any piece of tumor, which with ultrasound, you cannot leave big piece, but some border of the tumor tissue is not clear to differentiate. But the same problem is also happening in the MRI anyway. But it's nice to have intraoperative MRI. But I still love intraoperative ultrasonography, and intraoperative navigation is not working for me in any intrinsic brain lesions. And you know, some people are comparing intraoperative MRI and intraoperative ultrasound, which is not fair because they are different. Intraoperative ultrasound is very critical for, especially for navigation. It's that you cannot use in the MRI. And intraoperative ultrasound also you can perform 10 times in the surgery, but intraoperative MRI 1 or 2 times. So it looks like comparing with the car with the airplane. They are both are taking us from somewhere to somewhere, but they are different. And if possible, you need both. But if you have to choose one of them, I recommend to start with ultrasonography. It is more a critical issue in my opinion. And this is 3 months after surgery, radical resection of the posterior thalamic tumor using posterior intermispheric transdentorial substitutional approach without cutting any structure. And it was grade 2 astrocytoma. The third approach is the perimedian supracerebellar transdentorial approach. It is again very good approach for posterior thalamus pulvinar lesions, and this is also completely extraaxial approach, transcisternal approach, and the main advantage also preservation of the optic radiation. It is same midline incision, but how I learned from Professor Yaşargil, we go a little offline because that in this way we preserve the venous structures, venous system in the midline, and also we have less angle to go pulvinar. And I use the semi-sitting position for supracerebellar approach. This is the one disadvantage because when I use supracerebellar approach, I cannot use intraoperative MRI. This is the point. But for me, the semi-sitting position is more important than intraoperative MRI in such a cases. And transesophageal echocardiography is very critical issue for semi-sitting position. And then also surgical microscope is very important. I use Professor Yaşargil's original microscope from Zurich, and without autofocus and without zoom, so the very short, very light microscope, and I can work 10 hours. Of course, I have an armrest of Yaşargil also, but so my I don't stretch my arms in the semi-sitting position, and this is the position of surgeon when I use this approach.
This is the case of 20-year-old female who presented with a 2-month history of headache. She had no clear neurological deficit. MRI revealed a left-sided pulvinar tumor. The preliminary diagnosis was a low-grade glioma. The anatomical relationship between the tumor and the splenium prompted the PEST approach with the patient in a semi-sitting position. The fiber tractography shows that the left motor and sensory fibers are located lateral to the tumor. This illustration summarizes the steps of the PEST approach. A linear median occipital incision is made. Then, an asymmetric perimedian craniotomy extending more on the side of the tumor is done through 3 burr holes. The red arrows indicate the dural incisions. The first dural incision is made at the caudal end of the exposure to release CSF from the cisterna magna. A second curvilinear incision is then made about 15 millimeters under the left transverse sinus. After dura is open and hung, one of the main advantages of the semi-sitting position is revealed. One can easily appreciate the amount of supracerebellar space created without rigid retraction by the gravity and CSF release. Please note the perimedian tentorial bridging vein reaching to a tentorial venous lake, which are both protected throughout the surgery. Moreover, dissecting the arachnoid membrane facilitates cerebellar descent with gravity. The left-sided tentorium is then coagulated and cut longitudinally along the direction of the approach towards the tentorial hiatus. The arachnoid dissection is continued and the basal vein of Rosenthal is mobilized so that the left pulvinar is well exposed. Through the PEST approach, the tumor is reached without any cortical or splenial incision. The tumor is recognized by its abnormal appearance and the surface is coagulated before we enter the tumor. A tissue sample is collected for histopathological study. Frozen section confirmed the diagnosis of a low-grade glioma. After the tumor is debulked, it is dissected from the normal thalamic tissue at the inferomedial border with low-power bipolar coagulation. Now, the superolateral portion of the tumor is dissected and removed with forceps. The nurse controls the power of suction, which is managed continuously according to the surgeon's manipulations. Now, the supremedial part of the tumor is dissected and removed. Suction is used to gently pull the tumor enough to dissect along the borders. This is the anterior superior portion of the tumor, and it is removed with suction. Now, the inferior border of the tumor is dissected. Dissecting the tumor circumferentially facilitates the use of the ultrasonic aspirator, which is used at low power for removing the tumor anterior superiorly. When the superior portion of tumor is removed, the bilateral fornices are exposed. The lateral border is removed with suction. Use of the neuroendoscope is crucial to detect any tumor remnants hidden from the microscope's view. At first entry, the tentorial surface of the left cerebellum seems to be free of contusion. When the third ventricle is reached, the residual tumor tissue is detected at the superolateral border. The residual tumor is then removed under the microscope. Bipolar coagulation is done only when necessary for hemostasis and always used at low power. Neuroendoscope is once again employed to recheck the surgical cavity. Please note that the tentorial bridging veins are protected. There is no clear residual tumor or any active bleeding seen at the surgical cavity. The contralateral thalamus, the fornices, and the normal ipsilateral thalamus tissue are demonstrated. The supracerebellar and subdural spaces are covered with a thin layer of gelatin sponge to prevent postoperative meningocerebral adhesions. Both dural incisions are closed in a watertight fashion. Postoperative MRI confirmed radical removal of the tumor. Postoperative fiber tractography demonstrates intact motor and sensory fibers. The patient had no neurological deficit after the operation. Histopathology analysis showed a mixed oligoastrocytoma WHO grade 2. Therefore, the patient did not receive any adjuvant therapy.
So, and the last approach is the perimedian contralateral supracerebellar suprapineal approach. And this approach I perform only for third ventricular surface of the thalamus. And this is also completely extraaxial transcisternal approach, and also the preservation of optic radiation is very critical issue. And this is the case for this approach. This is the right-sided thalamus tumor, which is extruded to third ventricular surface of the thalamus. There are two ways to go there, maybe transcallosal, but you see there are normal thalamic tissue here. And if you go from this side, also you have to open the choroidal fissure, manipulate the fornix, and mobilize it, and so on. So I think this is the excellent case for contralateral suprapineal approach. As you know that Dr. Lawton used contralateral approach also for thalamic lesions, beautifully he demonstrated, but I use contralateral approach only for third ventricular surface of the thalamus, not for pulvinar. And this is, and it is interesting, most of the tumors in the pulvinar are high-grade tumors, but all of my cases with third ventricular surface of the thalamus were low-grade tumors. Each thalamic location also have different histological diagnosis. This is the sensory and motor fibers are so far from the lesion. Again, we use third ventricular surface of the thalamus and for this contralateral approach. And I use this approach for 5 cases. They are rare tumors, exactly, or cavernomas. And the same craniotomy, which I described in the before, I just use the contralateral. So for right-sided thalamic lesion, I use left-sided approach. And because after opening the suprapineal recess, you can directly see the third ventricular surface. The same opening of the cisterna magna, releasing CSF from cisterna magna. I also put catheter to leave there, and so therefore in the surgery we can have continuous this CSF release. And I use semi-sitting position for this approach. And then I mobilize these tentorial veins. I do not coagulate them. Even nothing may happen, but this is my attitude now to try to preserve. And I open the galenic cistern and to see the anatomy, and then the fourth nerve, and then go up to see the pineal. We have to see the pineal gland, and then we have to open the suprapineal recess to reach the third ventricle. And then with this way, with the left-sided approach, I can see the ventricular surface of the right thalamus directly. And this is also totally transcisternal approach. And you can see now, we are going to see the, yeah, you can see the tumor now. This is arachnoid. And you see the tumor is bulging. So we check with the endoscope, the left-sided supracerebellar approach, fourth nerve, midbrain, tectum, pineal gland, and the roof of the third ventricle, and for bilateral fornix, left thalamus, and right thalamic tumor protruding the thalamic third ventricular surface of the thalamus. So I get the sample from tumor and then try to find the border between tumor and the thalamus, normal thalamus. These are very interesting. These location thalamic tumors are all low grade and very well circumscribed lesions. And the suction and the bipolar dissection is the main tool for the removal of this tumor. And then we send the sample for frozen section. It was low-grade glioma. The inferior part of the tumor I am now trying to remove, which is more difficult. With this approach, inferior part, to reach the inferior part is more difficult. The superior part is easier. And then checking with the neuroendoscope, which is crucial. And you can see all anatomy very well. Anterior commissure, bilateral fornix, bilateral foramen Monroe, but there is residual tumor in the inferior part. So which I use the curved suction and the bipolar to remove the residual tumor. And I'm checking again the normal anatomy. This is roof of the third ventricle, choroid plexus, bilateral internal cerebral veins, anterior commissure, bilateral foramen Monroe, left thalamus, right thalamus. And this is postoperative MRI. Goes, you know, this is my direction to go this to remove this tumor. And this is visual field after surgery. And it was grade 1 tumor. And in most of the cases, I had experience with the temporary port gaze palsy, but they recover. But in 2 cases, it didn't happen. But this may happen, but it recovered. So also you can, we publish this approach, you can see it. The most important factor in the thalamic tumors, extent of resection and histopathology. Low-grade tumors may be curative, but better prognosis in high-grade tumors. If the tumor is small and if the tumor has a long history of symptoms, it's good outcome. But if the patient has a raised intracranial pressure and high-grade tumors, worse outcome. And children has better outcome than adults. Now, my number is reaching 120, but this is my statistics for publication, so I put this one. But now my number is almost 120, and mostly adult patients. And I use 4 approaches, and never from neocortex. And mostly use anterior interhemispheric transcallosal approach because, first of all, now I can use intraoperative MRI. Second, also I can perform third ventriculostomy, microscopic third ventriculostomy. And then posterior interhemispheric transdentorial approach, which is also I use a lot because that also I can use intraoperative MRI. But there are some cases that not suitable for these 2 approaches. I use supracerebellar approach, which is very important in my opinion. Now this number is 6. I use 3 cases more. So this picture is summarizing artistic picture of Mr. Roth from Zurich. Draw this picture. We were lucky to summarize all the philosophy of thalamic surgery. And some cases I had to do 2-3 surgeries for recurrent tumors and also for CSF problem. CSF problem is the main issue when you deal with the thalamic lesions, because that most of the thalamic lesions, gliomas, you know, we have big number of glioblastomas in thalamic lesions, which if the glioblastoma can produce CSF problems. So we have to keep in our mind that high-grade tumors can produce more CSF problems, so we have to be ready for that. So more cases with high-grade tumors. We have no surgical mortality and one major surgical morbidity. CSF circulation, which I mentioned, in 7.6 patients, we have to deal with the CSF circulation problem in the first early postoperative periods. And most of the patients are same or better than preoperative period. Microneurosurgery and with the usage of neuroendoscope permits safe removal of thalamic lesion with acceptable risk of morbidity. Management has to tailor to individual patient. For surgical planning, neuroimaging is essential to understand the growth pattern and extent of the lesion. So we have to understand the growth pattern and extent of lesion, and then we have to decide which approach we have to use. In our experience, virtually all thalamic lesions can be accessed. However, to be honest with you, there are very small cavernoma in the center of the thalamus I do not touch, because that to get there, I have to damage more thalamic location. But thalamic tumors is another one. Thalamic tumors try to get somewhere, but I have some cases that I did not do surgery. Very small thalamic cavernomas just inside of the thalamus. Otherwise, it's possible to reach any thalamic tumors using these 4 free thalamic surfaces: lateral ventricle, velar surface, velar surface, cisternal surface, and third ventricle surface. These approaches facilitate optimal intraoperative orientation and access to one or more of the 4 thalamic surfaces without unnecessary manipulation of brain parenchyma. And I try to use low and high-grade tumor, doesn't matter. If I feel that I can remove it, I recommend surgery. But of course, there are some glioblastomas, high-age patient, and multifocal glioblastomas. It's difficult to do surgery, but we have to deal with the patient's conditions and expectations also. Radical resection is the goal, any type of tumor, low grade or high grade or cavernoma or whatever. Adjuvant therapy utilized if the high grade tumor we recommend adjuvant radiotherapy and chemotherapy. Again, I mentioned high-grade glioma seems to be more likely to develop postoperative CSF problems. And then for this reason, I am thinking to use anterior transcallosal approach whenever possible, because that, again, using intraoperative MRI and also microscopic third ventriculostomy. And I really spent a lot of time with thalamus. I spent a lot of time thalamus anatomy, and then I spent a lot of time in the operating theater, and then also the intensive care unit with the thalamic lesion patients. And I had more gray hair with the thalamus. Unfortunately, this I think largest series of thalamic surgery is going to be published in Journal of Neurosurgery, and I'm very happy that it will be in the cover of Journal of Neurosurgery. And in conclusion, there are many new modern tools in now, and it's nice to have all of them. And I have all of them, and I'm very happy to have them. And if there is something new, I like to use, because nothing is enough to do better neurosurgery. So I like to improve my quality of my surgery. But we should not be dependent on these technological developments or something. We need to put this information all together in our brain. And then we have to put our surgical anatomical knowledge and then the correct indication for our ability. You know, the indication of surgery depends on the ability of surgeon also. this kind of tumors or lesions. And choose the correct surgical approach and microsurgical technique is very important points in the success of neurosurgery. Of course, this is not my work alone. My residents, fellows, nurses, and all team, and my colleagues from neurology, anesthesiology, and other team to work together. Otherwise, there is no chance to be successful. And I look forward to see you next year. This year it looks not possible with COVID-19. June 2020, please note, and we hope to meet you in Istanbul. Thank you.
Okay, Juha.
Thank you, Ugur, for this excellent lecture in the large series of thalamic lesions. It was a wonderful lecture, and we learned again very much. And I have used 3 first of these approaches in my cases in Helsinki, but of course the number is by far lower here. So the discussion is open. I saw some questions in the chat box. Please go ahead. At least Harshat had one question. Okay, please go ahead. Comments?
Hello, Professor.
Harshat, you had something
Yeah.
to ask.
It's
Yeah.
excellent presentation, spectacular videos, superb demonstration of the surgical techniques. I just wanted to understand in what are your criteria to go contralaterally, whether it is in interhemispheric transcallosal or a supracerebellar approach. What makes you to decide?
You are asking me about contralateral.
Yes,
approach.
yes, Professor.
I use contralateral approach only for third ventricular to reach the third ventricular surface of the thalamus, because in the cases, special cases in third ventricular thalamus, you cannot get through the pulvinar. Pulvinar is totally intact. You cannot get from the anterior transcallosal because anterior thalamic nucleus and the lateral ventricular surface of thalamus is totally intact. I found that this is the better approach to reach third ventricular surface of the thalamus with the contralateral, because you cannot get in the ipsilateral. So you have to go contralateral. And this is my choice. I am not telling that this is the only way. No, this is my choice. And I found very useful and less invasive to go there, because it is totally transcisternal.
Thank you, Mr.
Yeah.
Professor Correa?
Yeah,
I have a question.
Sorry.
So you mentioned that you prefer to use transcallosum approach, but you know, the midline, there's sometimes there's a lot of veins. So what kind of spatial examination before you choose approach?
Yeah, yeah, this is very important question. In my video, I try to explain. We use Osirix and to see the 3D reconstruction of the parasagittal venous anatomy. And then I put my craniotomy depends of these veins. And there are 2 factors. One is the position of the veins. Second is my angle. You know, if I go anterior thalamic, I cannot go from posterior. I have to go as anterior as possible. So 2 factors, my angle of approach. Second is the venous anatomy. I never coagulate the parasagittal veins to get interhemispheric, but I struggle, some cases, I struggle a lot. And in one case, I use left side approach because of this venous anatomy also. So when I perform my craniotomy, I can switch the left side also. If really the right side is totally blocked with the veins, instead of coagulating veins, I use left interhemispheric approach.
Great. That's very reasonable. Thank you.
Yeah, Ugur.
Mhm.
Hi, my
That
friend.
was,
The king is here. The king is here.
that
If
was
I
a
knew that
wonderful-
you are here, I would be more nervous, you know.
That was a wonderful, wonderful presentation, Ugur. There is no question that you have got a fantastic experience with these intraaxial tumors. Today you showed thalamic tumors. The other day you showed midbrain tumors. And I don't think anybody in the world has that kind of experience with such radical resection. And I congratulate you for your beautiful exposition of your technique and of your courage. You see, I can believe that these kind of operations can be done only if you have very fantastic knowledge about the fiber tracts, about the anatomy of the region. You see, to go supracerebellar, infratentorial to the thalamus, you have to have the anatomy of the pineal gland, anatomy of the venous structures, and also the distance becomes quite large. And also sometimes, I want to actually ask you, sometimes, have you ever experienced with that large distance and limited exposure, some bleeding issue that you were not able to see properly, or some issue? That is one question I want to ask you, because the distance becomes a little bit bigger. The other thing is, you see, as you rightly mentioned, these approaches can be done only if you are doing in sitting position. Nobody can do this operation if you are not doing in sitting position. You see, if you are not doing in sitting position and prone position and concord position and all those things, I don't think this can be even attempted, these kind of operations. So my feeling is those who are more experienced in sitting position, that is one. Second thing is fine anatomy of the tentorial incisura, about the pineal gland, suprapineal axis that you have mentioned, the venous anatomy of this area, and the control of venous anatomy, the dissection in proper plane, identification of tumor from normal structures is such an important thing. You see, when you're removing glioma, as you said, thalamus itself is like glioma. So when you are removing the tumor and you bypass the glioma, that can be another, can be a problem. Now, to extend your this thing, I want to know your experience. Do you have the same attitude with hypothalamic gliomas, or you think you have a little bit different attitude? Hypothalamic gliomas.
Hypothalamic gliomas is totally another story. And I am now working on my new paper with hypothalamic gliomas. Interesting. Thalamic gliomas never invade the thalamus. Hypothalamic gliomas never invade the thalamus, which Professor Yaşargil mentioned this 30 years ago. That hypothalamic sulcus is the border. And most of the thalamic tumors are high grade. Almost all hypothalamic tumors are low grade. This is also another issue. But hypothalamic gliomas are another issue. I use transcallosal approach, pteronal approach, or combined approach of Yaşargil for hypothalamic gliomas. This is totally a different story. Your second question was about...
Ugur, before you go further, I want to know, are you as aggressive in hypothalamic glioma?
Exactly. I am not aggressive. Aggressive is a bad term. I am a very mild person. I am not an aggressive person. I never fight with anyone in my life. But if I decide to remove, I have to remove as much as possible. Of course, chiasmatic gliomas is another story. We have to differentiate from the hypothalamic gliomas. In some chiasmatic gliomas, you have to leave some piece to prevent this vision. But the hypothalamic gliomas, I have to remove totally with preservation of stalk, because hypothalamic gliomas are arising from one hypothalamus. I never have bilateral hypothalamic glioma. I never seen. So the tumor is from one side, and many times preoperative MRI doesn't tell you which side is the origin, but in the surgery you have to find out. And you have to preserve other hypothalamus, and if you preserve other hypothalamus, you preserve the stalk also. This is another story. So, but hypothalamic glioma, I have to remove totally. This is my goal. Of course, second question about the semi-sitting position, I do not use supracerebellar approach without semi-sitting position for thalamus. I use this approach for mediobasal in lateral position. It is difficult but possible. But prone position, I did one time and I will never try again. So I do not recommend prone, concord, whatever position for supracerebellar approach. Semi-sitting position is excellent for supracerebellar approach. This is my choice. Another point is the very deep location and the vascular control. To be honest with you, it is not very deep. You know, when you go paramedian or perimedian to reach the thalamus, thalamus is very short distance. I am going to remove amygdala. So amygdala is 2 times further than. So thalamus is not far. And so I use 95 millimeter bipolar forceps, which my maximum is 135. So thalamus is not very far. And the vascularization of thalamus itself is very simple. You know, the thalamoperforating arteries they are running radically, and there is no problem with the arterial vascularization because there is no big artery. But the venous anatomy, you have to preserve it. You have to preserve precentral vein. You have to preserve branches of galenic system. I did not have any problem with the what you mentioned, the control of the bleeding yet. But this is neurosurgery. Someday maybe I can face, but not yet.
Another question, Ugur, I want to ask you. When you are doing thalamic tumors, like you showed, what are the things that worry you? What are the things that you think, what are the dangers that you anticipate when you operate?
The main danger is the goes to internal capsule. I think this is the main point. You know, when you deal with the thalamus, you have to preserve the venous anatomy. Arterial, because arteries are not big deal, but the venous anatomy is the main point. Starting from the tentorial veins or parasagittal veins, and then internal cerebral, thalamus, all you have to think about the venous anatomy. You have to preserve it. Arterial system is very simple in thalamus. Fortunately, arteries of thalamus is totally different than arteries of internal capsule. So this is great. But veins of internal capsule and corona radiata, thalamus striate, the name of thalamus striate vein is wrong. The thalamus striate vein receive blood from internal capsule and corona radiata. If you damage it, you are in trouble. So venous anatomy is the most important thing, and also don't damage the internal capsule. Internal capsule never invaded by thalamus tumor. So we have to preserve it. And always I have to be careful to not go inside of the internal capsule, but fortunately not happening yet, because also thalamic gliomas or thalamus itself, the tissue is totally different than internal capsule. Internal capsule is total, strong white matter, but thalamus looks like a glioma. So, but the main concern is the damaging any venous system, and then also the damaging the internal capsule. And then another point I mentioned, CSF. CSF, always you have to keep in your mind, CSF can give you a trouble. And, you know, I had complications in neurosurgery. maybe 90%, more than 90% are because of the CSF, not CSF fistula, CSF circulation. If you get a trouble with CSF circulation, you can have a trouble.
And my last sentence is, you know, when you're doing such tumors, Ugur, you have to have the hand of God behind you, hand of God. And you are lucky that God is always behind you. And that is the power you have that nobody else in the world of neurosurgery has. So beautiful presentation, Ugur, and I really enjoyed it. And my association with you has been several years, and I know everything about my dear friend Ugur today. Thank you, Ugur.
It's great to hear this from you. I know how you are honest, and you can do critics for very honestly. It's great honor for me to hear such things from you, and I promise you I will improve.
Thank you. I think for Radab, you have a comment or question? Unmute, Radab.
Yes, Dr. John, thank you, Professor Ugur, for this insightful presentation. And thank you all professors for us having an honor to be with you in this wonderful presentation. It's really an honor for us. You're welcome. Professor Ugur, I have two questions actually. My first question was about the lateral surface thalamic lesions. You mentioned that it is mainly high-grade gliomas, while those with the ventral surface would be of low-grade glioma. Do you have any?
What is your question?
You mentioned that the lateral surface gliomas on the thalamus lesions would be of high-grade gliomas, while those on the ventral surface would be
I say posterior, pulvinar tumors are mostly high-grade, and if the tumor extrude the third ventricular surface, they all were low-grade. They are rare tumors, rare location, third ventricular surface tumor. But they, in my series, they all low grade. Yes.
Okay. Do you have any specific explanation for this, or it's just a coincidence?
No. I mean the gliomas. You know, Professor Yaşargil mentioned this many times. There is a predilection size of the tumor. Tumors are not crazy. You know, they are choosing some points that. For example, hypothalamic gliomas are low grade, thalamus gliomas are mostly high grade. This is also an interesting issue. So in the pons gliomas are mostly high grade, midbrain gliomas are mostly low grade. So this is all brain has this kind of issues that there are some predilections side of the some tumors.
Okay, thank you. My second question is about the morbidity. What was the most common post-op morbidity? Was it disconnection syndrome?
CSF. Okay. CSF disturbance. You know, because if CSF cannot circulate well, you are in trouble. You know, you have to open the septum pellucidum. You have to open the. You have to perform third ventriculostomy, because you don't. Trust the aqueduct, because aqueduct can give you trouble, because you have to open new things to aqueduct. Because of the also early cerebral edema, aqueduct can be closed easily. So the main problem I faced with the third ventricle surgery was the CSF problem, CSF circulation, not CSF leak, not CSF leak. I wish CSF leak can prevent problem. CSF circulation problem. You know, this is, we have to be ready for this, and all of the cases that the CSF problem I faced was high-grade gliomas. So high-grade gliomas, they also give some material, maybe CSF, and the tissue itself of the brain is also different in high-grade gliomas. They are not firm enough. They are more soft. Soft brain is not good.
Okay,
what about disconnection or transient mutism? Did you face any significant number of disconnection syndrome and transient mutism during the colostomy?
No. I had a problem with CSF, but not this connection syndrome. But I had CSF problems. So.
Thank you.
Which is my morbidity, one case, major morbidity, because of the CSF. I operated 7 times, put another shunt, 2 shunt, 3 shunt. Every ventricle needs another tube. So, you know, because the problem is also that each part of ventricle may have produced trouble. So this was my major morbidity of case because of the CSF problem.
Go ahead, Juha. Go ahead, Juha.
Yeah, I see Professor Osama Al-Mefti is here. Do you want to say some comment?
Professor Hernasimi, Dr. Bennett, everybody, thank you so much for bringing this beautiful, informative, learning, masteral lecture. I spend quite a bit in the morning trying to be sure that all my fellow and the friends are tuned and they sign up to learn. So Ture, like always, thank you so much. This is the important here, not just to see the masterful things, the important how you're teaching us how to do the right things. Now, as you know, I'm hanged on the little details, and my good friend Dr. Goel always poked me to speak loud. And so I do want to take issue with you and him. Sitting position, I done sitting position for 50 years. I know how good it is and I know all of its advantage. But sitting position is not a must to do these cases. Sitting position has its own disadvantage even in these cases. And I want to tell you honestly that I heard your comment about it, but if you just follow me for a second, forget prone. Prone is terrible, okay? Now, there is something called concord, which is the head is really high. The head is flexed down like the Concorde airplane. And that will give you really a very nice shot there. The problem with it, that's in a prone position, you lost all the advantage. If you put the patient in a 3/4 prone, one side high, one side low, it depends how you want to aim. It's the most beautiful, simple, straight exposure to the whole pineal area and beyond to the thalamus. So I want to disagree with Atul like I always do, as much as I love him. You do not have to have a sitting position. You could do that surgery beautifully through, it have to be very done right. What we call a 3/4, not prone, 3/4, and has to be concord correctly. And then you could sit on a short distance, straightforward. And the advantage of it too, if you want to cut the tentorium, it gives you the very back of the tentorium to the transverse sinus, which back of the tentorium and the transverse sinus is difficult to really visualize within a sitting position. A 3/4 sitting, I know you have your all position. So I'm not just disagreeing. I'm afraid that tying this beautiful surgery to a position might be deterrent to people to do this beautiful surgery. And the other question I have for you, and you have said it so beautifully, it seems in children, It's a pilocytic astrocytoma, and they are more anterior, and they need to be removed totally. And they have beautiful prognosis if it's not cured. The posterior one in adult or the pulvinar are overwhelming glioblastomas, and they have terrible outcome comparing with the glioblastomas even anywhere else. Is there if you know that it is a glioblastoma in adult patient in the thalamus, do we need to do that surgery, or it's enough to confirm the diagnosis?
Yeah. Maybe I start from your last question. Yeah. You know what? I operated a glioblastoma. I knew that preoperatively it was glioblastoma. But if the patient condition is good, and if the glioblastoma has a good border, I operate them. But there are cases that there is 4 cases that we just made stereotactic biopsy because the tumor was, the patient condition was not good, and also the tumor was not, doesn't have a good border. I didn't operate. But if the tumor, if the glioblastoma, it has a good border, and if the patient is younger age, if the condition of the patient is good, I operate them. And I have similar results with my temporal pole glioblastoma. I mean, yeah, glioblastoma is glioblastoma. This is reality, of course. But, you know, I still would like to give some chance to patients, especially younger patients. But old patients, we have to think more for glioblastoma.
Can I say one more thanks? Thank you again. It's a master surgery, beautiful lecture, great experience. We learn so much from you, and always love to listen to every word you say. The beautiful things you are doing, that you're embedding the experience of you got Yazar Gil sitting there with you now for 30 years and thought. So this, to embed the wisdom and the technique of a past giant is a beautiful one. And one of those wisdom is Professor Sugita and Kobayashi. When they went interhemispheric and that vein was crossing in their way, they described a way to separate the vein from the cortex, so you could preserve the vein and be able to relax the cortex away from the fault. It's a beautiful technique. I used it over and over again.
I used also, I saw from you, yeah.
Yeah, you do not need to cross and go to the left side. You could just free that vein and go down.
Yeah, I agree with you, and I mobilized that veins. But in one case, really, I was totally stuck because of my angle. You know, I have to go from anterior. So in one case, I had to go left side. But there is always some way to manipulate that venous system. I totally agree with you, and I use the same technique. And about the semi-sitting position, of course, Professor, I mean, you are my mentor, and I always listen you, and I try to follow you. But I try to use Concord, and I find out that semi-sitting is much better. But to be honest with you, I have the best neuroanesthesiologist, who is my wife.
Not just the best person on earth. Not the best anesthesiologist.
I am lucky neurosurgeon. So, of course, if the team is not comfortable with the semi-sitting position, they should not apply. I totally agree. But my point, we should not kick out semi-sitting position from neurosurgery. Semi-sitting, every position has a problem. prone position is more trouble in anesthesiological view, in neurosurgical view. Every position has some disadvantages. Of course, semi-sitting position has also disadvantages, but depends on the cases. I like to use it and I'm very comfortable and I didn't have trouble yet. And I had a lot of advantage of semi-sitting position, but I didn't deal with the big problems with semi-sitting position. But of course, if the 80-year-old man with the great hydrocephalus and cortical atrophy, this is not suitable for semi-sitting position, in my opinion. We may have a postoperative pneumocephalus problem, not only the air embolism, but with this, my position, 25-degree position, believe me, air emboli is not the problem. With the usage of ultrasonography, the transesophageal ultrasonography, because we can see any single air bubble before any trouble, so we can move the patient down. I don't put the patient in 90-degree. I put patient in 25-degree. But of course, if you are comfortable with the Concord position, perfect. I mean, this is just my choice in these days that I still like to use because I use Concord position for pineal, but I find this is better. But I never try with the quarter prone. So I will try, I promise you. Thank you very much, Professor.
Thank you.
It is great honor for me to talk with you and discuss with you as my mentor.
It's a great learning things and so great pride to see the beautiful work you're doing.
Thank you very much.
Something more? More comments?
Thank you, Dr. Agor, Dr. Osama Mufti. Thank you all.
Can you identify yourself, please?
Okay. Well, I tell you about this Arabic word for thalamus. Thalamus is meaning mihad. Mihad.
What?
This is the basic. Mihad.
Mihad.
Mihad. Al-mahad. Al-mahad is the beginning.
Ah, beginning.
المهد من المهدي إلى اللحدي. المهد من بداية. The beginning of all the world, of the earth. Big Bang theory, like this. المهد. You see? This meaning. This is hypothalamic metaphysics. You know? Like metaphysics, hypothalamus. This is thalamus and the cortex and hypothalamus and all the below cerebellum and below. Like this. This is Arabic. This other question for the CSF circulation problem. CSF circulation problem. What do you think this from? What comes the circulation problems? You open all the opening, aqueduct, and why comes circulation problems? Do you think?
When you open the microscopic third ventriculostomy, this will not happen. So this is the reason. After experiencing with this, I performed third ventriculostomy routinely when I used transcausal approach. So this is what I learned from my complications.
Oh, you want to put this one shunt, one shunt. I said why? On ventriculostomy, okay.
Oh, another point. You may have a partial ventricular dilatation with glioblastoma patient. This is happening. Yeah, partial. So you may have only temporal horn because in the atrium collapse and the patient may have only temporal horn enlargement. So what you will do? Trouble.
Yes.
And then you can open that temporal horn and the other ventricle may be collapsed. This happened to me.
Thank you.
You're welcome.
Good presentation, Dr. Agor. Good presentation and good lecture.
Thank you very much.
Thank you.
Okay. Any more comments, questions for anybody? Juha? Do you want to wrap it up, or what do you want to do, Juha?
I don't see any other in the chat box. So I think it was a concluding wonderful surgical experience, wonderful discussion, also good comments, and I thank you all. I think next Friday we make a break because it is May 1 next day.
Okay.
So at least in China, the audience will not be the same at usual Fridays. So
okay,
in
very
2
good.
weeks we will meet each other again. So
okay.
Professor Mastronavi from Rome is speaking then.
Yeah, very good. Very good. Okay, Dr. Ben, how did we do today in China?
Fine. I checked the audience number. It's around it's more than 1,000 audience attend this webinar. Yeah,
great. And thank you for translating. Thank you for translating. Takashi, are you there? Takashi.
Good evening. Good evening. I'm Dr.
Hello,
Kang from Tokyo. Good evening. You are. Thank you, Dr. Gutierrez. So very thought-provoking. I'm so operating glioma, but the thalamus, glioma, the thalamus is very deep, and without navigation, the 5-ALA, we have some difficulty in operating them. So I'm very interested and very informative. So I have to learn cadaver dissection. Someday I will visit your institute and study further. Thank you.
Thank you.
Very good.
Thank you.
And Takashi translated into Japanese in real time. So you read some Japanese docs too, Dr. Chor.
Very
good.
Thank you very much.
Good many Japanese friends. I know several Japanese doctors, and they are connected to Dr. Gutierrez. So.
Thank you very much. Thank you.
Okay.
Thank you.
Okay. Thank you, everybody. Thank you very much.
Okay. We'll see you in 2 weeks, everyone. Thank you, Dr. Chor. Thank you. 2 weeks.
Thank you.
Bye. Bye, everybody.
Bye.